want to welcome a guest from Italy, Dr. Natasha Di Lorchi. She graduated from the medical school in Genoa. She's a pediatrician and a geneticist, currently Associated Professor of Pediatrics, OMGA, University of Genoa, Italy, since 2015. She has many publications in peer-reviewed international journals with several oral communications at several national and international congresses. Today, her talk is going to be about endocrine consequences in long-term survivors of pediatric brain tumor. Welcome.
Thank you very much for the kind invitation. I'm very happy to be here. I would like to thank the scientific committee for the invitation. Sorry. Should I go and search mine? Okay, sorry. Yes. So I would like to share some insights on this topic. It's very near to my heart, and we will all face long-term cancer survivors. And I think I will convince you at the end of my presentation that really, as endocrinologists, we have a huge role in improving the quality of life of these patients. So going through the epidemiology, I will try to answer to 4 questions. Who is at risk, how to suspect, when to diagnose, and what to do, finishing with recent guidelines. I will spend most of my time in trying to answer to the first question, who is at risk, because the aims of my presentation are really to reasoning by risk factors in order to predict, prevent, and diagnose as early as possible the 3P mechanism. I like to tell a bit about this. So, more or less, 170 new cancer diagnoses per million persons are diagnosed every year in the US. We know that leukemia is the most frequent cancer, followed by brain tumors and lymphomas. But what we don't really know is that in the next years we will face a huge problem. 500,000 of childhood cancer survivors maybe will come to our attention. And why is so important? Because half of them will present at least one endocrine consequence. So going and moving to the first question, who is at risk? I asked for help to my child, on the left-hand side, treated with chemotherapy, on the right-hand side with radiotherapy. I highlighted in red all the consequences on the endocrine system. As you can see, alkylating agents will give gonadotoxicity, but is certainly radiotherapy the most important risk factor for all our endocrine system, at the pituitary hypothalamic level, at the thyroid level, at the uterine gonadal level, and also at the bone level. So when I meet for the first time a survivor, I ask to myself, is there a mass, and which are the involved adjacent structures? He underwent surgery, was this partial or a total resection, and about radiation, the site of radiation, the type of radiation, the amount of dose, the fractions, the time that between the fractures in order to consent tissue repair, and about chemotherapy, which was the class of chemotherapy, and if he underwent also immunotherapy. I always take into account the age of treatment, the age of evaluation. Puberty is one of the main focus of this course, and gender. So this is the case of Sveva. She had a diagnosis of a disseminated medulloblastoma at 4 years and 8 months. As you can see, she underwent a very heavy chemotherapy cycle with many alkylating agents for 14 months. She also underwent 2 radiotherapy cycles, as you can see, at the spinal side, twice at the posterior fossa and also at the thalamus level. These were very, very high, as you can see, grades. And she came at our attention after 18 months of treatment. So this growth chart is not really since the beginning of the diagnosis. And at the beginning, she was absolutely normal for sex and gender, and also for target height. But as you can see, the last time she developed a growth deflection with a minus 3.8 STS for growth velocity. So really, we didn't have really 12-month growth velocity, but just 8 months. But we decided to perform the first growth hormone secretion test with arginine that turned to be absolutely pathological, although IGF-1 levels were normal. Zveva allows me to talk also about central hypothyroidism in these patients. As you can see, the TSH is jumping around the number 10, a little bit lower, a little bit higher, and the 3 to 4 is progressively decreasing. We need to treat this central hypothyroidism. And allows me also to talk about hypergonadotropic hypogonadism. She was small, she was just 7 years of age, but as you can see, gonadotropin are very high. And this allows us really to have the opportunity to optimize timing and treatment when she will need to enter puberty. The imaging evaluation was normal: bone age, the ultrasound of the thyroid, of the pelvis, and the DEXA scan. So she started thyroid, and her growth normalized, but just when we added growth hormone, really we had an initial growth, pitch-up growth. So already 10 years ago, Darcy and Charlotte tell us that a very high irradiation to the hypothalamic pituitary level needed to a 100% growth hormone deficient patients in 5 years, and also a high prevalence of all the other hormone defects. And they told us also that growth hormone is for sure the more radiosensitive axis, followed by gonadotropin, ACTH, and TSH. But I wanted to focus on ACTH deficiency, because people can die if we don't recognize this, not if we don't recognize growth hormone deficiency, at least in the short term, but ACTH deficiency, yes. And in 2016, Clement, looking at more than 700 cancer survivors at the age of 15 years of age, 6.6 years after of treatment, discovered that 22% had at least one endocrine defect, and in red and in blue, I would like to point out that diagnosis of growth hormone deficiency and TSH deficiency was still done after 8 and 10 years respectively. They always also told us that there is no tumor histology completely safe, although for sure medulloblastomas and low-grade glioma are mostly associated to endocrine dysfunctions, and also told us that there is no treatment strategy completely safe, although for sure the combination of neurosurgery, chemotherapy, and radiotherapy is mostly associated to endocrine dysfunctions. By multivariable analysis, turned out the radiotherapy and suprastellar location were for sure the mostly associated to these dysfunctions, but also the infratentorial side, hydrocephalus, and a younger age diagnosis, and together an advanced follow-up. So, which are the perspectives? We know that we have new photon radiotherapy strategies and proton beam therapy. What about the first question? I would like to share some personal data. We have assessed the impact of the radiation dose to the pituitary in the radiotherapy technique on the frequency and timing of onset of different hormone defects in a cohort of patients that were treated before 16 years of age. And we compared a group that was treated with conformal radiotherapy and IMRT. So we selected 64 patients, mostly were medulloblastoma, followed by glioma, and we calculated the actual dose to the pituitary by the two techniques. What we found that for sure patients treated by IMRT were exposed to a lower dose, but was not significantly lower compared to the other group, but for sure we had a lower prevalence of all our hormone defects. We saw also relation with dose. The higher dose in yellow, above 40 grays, was associated to a more or less 76% of deficiency, up to 6 years, but we had a safe dose only in the patients below 15 grays. So we don't have really other safe doses above 15. And in the right-hand side, you can see the picture, the design of the exposition by IMRT. You can see the other adjacent structure may be involved. So this is the reason why there is a strong effort to see if really the proton therapy is safer. And indeed, you can see that the irradiation site is much smaller. And in this published paper, they compared medulloblastoma treated with the two techniques, and they saw that really hypothyroidism and sex hormone deficiency was less present, and also height was preserved. But we have still a long way to go because we miss still long-term follow-up studies. So we are not so sure yet to say, yes, proton therapy is the best thing to do for our patients. So the last topic of who is at risk is immunotherapy, and I would like to share this very recent systematic review that included 101 randomized clinical trials, and as you can see in the table, I just highlighted the results with monoclonal antibodies against the programmed cell death 1 with ligand, and as you can see, you can have endocrine dysfunctions, increase with combination of therapy, and it seems like the diabetes mellitus and primary adrenal insufficiency are less frequent with monotherapy. So this is the safe part. So moving towards the other three questions, I will try to give you insights together to these questions and how we suspect. There is a clinical red flag, and in example, height, specifically high deflection in irradiated patients, specifically at the spine level. But we could have also a biochemical red flags. Can you remember ACTH deficiency? For me, is very important, this topic. So remember that also a baseline cortisol when it's low or when it's high is not so sure, so we need to go and search for it with an ACTH low dose test, and if we are able to do it and to perform it, also an insulin tolerance test in order to treat with glucocorticoid patients that are totally or partially deficient, in this case just with stress dose. So what surveillance modality? Again, Darcy published lately this graph on the right-hand side showing that the GHRH plus arginine test doesn't perform well and is associated with the reduced growth hormone secretion. The most we have a long follow-up from of treatment, and we recently saw the same thing, although this deflection was not significant, maybe because we have analyzed a shorter follow-up, not 30 years but 14 years. And these findings agree with this recent review published in JCM in 2018. The authors conclude the diagnostic accuracy of various dynamic tests is the same in cancer survivors compared to non-cancer survivors cohorts, but the interpretation of the GHRH test is absolutely challenging, and we should not use the IGF-1 alone for this diagnosis. What about treatment? The indications are the same as in non-cancer survivors, but we need to keep in mind that we need to wait at least 1 year after remission or MRI stability. We will treat with a minimum efficacious dose based on IGF-1 titration. We should not go above +2 SDS. There is another point, maybe that sometimes, specifically in irradiated patients, we will not really have a catch-up growth, but already stabilized height will be a result. And I will share again some data in blue, craniopharyngioma and astrocytomas of the pituitary region, in red, medulloblastomas. They were all prepubertal. So the first one was structural GHD, the second group was an irradiated GHD. The first group just progressively increased their height. The second group stabilized their height after 12 months with a net gain that was half the one obtained in the first group. Although they were treated with the absolutely comparable GH dose, and as you can see, IGF-1, there was a complete and perfect adherence. And this systematic review that included 29 studies confirmed that really we have a significant increase in height when we treat these patients with growth hormone treatment, and we might also improve lipid profile and quality of life without increasing the risk of diabetes and secondary tumors, but we need still data about this. And moving to the last topic, guidelines. The Endocrine Society last year told us about GH diagnosis that they recommend periodic clinical assessment for GHD in this cohort of patients, and in all the ones that were treated above 18 grays, they recommended against evaluating just IGF-1 and also against the use of GHRH alone, and they recommended not to test patients that already had 3 hormone defects. About treatment, they suggested to wait 1 year disease-free, pointing out that many patients will never be disease-free, and then we need to talk about treatment with the oncologist. And they advise us also to treat with the same dose that we use in non-cancer survivors. So I will move just showing you that in a large cohort of patients, 145, we found that half of them were obese based on BMI, and 2/3 were obese at the visceral side, so central obesity. And when evaluated a region of interest by DEXA, trying to calculate really how much fat you have in the center, what we found by multivariable regression analysis after correcting for anthropometric variables and also cardiovascular risk factors is that IGF-1 levels negatively predicted visceral adiposity by DEXA, telling us that maybe we're not treating still well our patients or with lower doses not sufficient. I'm concluding. I'm working since 2013 with this International Guideline Harmonization Group, with the collaboration also with the Cochrane System Review Database. And we have published 6 guidelines, highlight the ones that are interesting for us. In 2016, premature ovarian failure, and in 2017, gonotoxicity in males. And just 2 insights. Sometimes we have the association of growth hormone deficiency and gonadotropin deficiency, and if we have peripubertal children, this is a problem, because we need to optimize height, but we need also to treat hypogonadism. So this is really to keep in our mind how to balance the 2 treatments and the tempo. We are working right now on these other 11 guidelines. Lately, this year, will be published the hypothalamic pituitary dysfunction guidelines. This is a preview of one table. You will see for each question a table synthesizing the actual evidence. And for GHD, what is interesting is that the latency is from diagnosis of tumor up to 15 years after diagnosis. And the cumulative incidence increases over time and does not seem to plateau. So, in conclusion, who is at risk? We saw radiotherapy, suprasellar infratentorial tumor site, hydrocephalus, younger age diagnosis, and advanced follow-up are risk factors. Maybe that radiotherapy below 15 grays, IMRT, and proton radiotherapy will be safer. How to suspect clinical follow-up every 6-12 months after to 15 years or maybe more. Growth velocity must be in the center more than short stature, or an evaluation every 12 months, 6 months if we have patients at risk. Rule out ACTH and do dynamic testing for GHD. When to act as early as possible. Puberty must be in the center of our thoughts, and give growth hormone therapy after 1 year remission. What to do? For GH, use IGF-1 titration, hydrocortisone also in stress dose when you have deficiency, and treat GHD before gonadotropin deficiency when possible. And I would like to thank you for your attention and all my group.
We have 1 or 2 questions. Yes, the floor.
Thank you so much for such a wonderful talk. It's actually very important, and of course, obesity is a major concern. But my question is about growth hormone. How long do you treat with growth hormone? Do you stop forever? What do you do?
Well, we test again all our patients when they reach final height. We wait at least 1 month stop therapy, usually 6. And right now we are undergoing evaluation with 2 tests. International guidelines says use ITT, insulin tolerance test, or the GHRH plus arginine test to test these patients. The problem is, as you can see with the Endocrine Society guidelines, we shouldn't use the GHRH plus arginine test in these patients. And the ITT, the insulin tolerance test, sometimes when we have epileptic patients, we can use them. So when we manage to use this test, we use this. Otherwise, we use the glucagon test.
No, but do you stop growth hormone?
No. If they are permanent growth hormone deficient, then we will go long.
Yes.
If they're
because of the
normalizing,
adult
but for
consequences.
sure the structural GHD will never improve.
Thank you. 1 quick question. If they have a relapse, would you start growth hormone after the second relapse?
Again, we stop, we wait 1 year, we talk with our oncologist, we balance pro and contra.
It's mainly about medico-legal issues. So if it's second time, if you have the courage to do it after a 1 year remission?
Well, happens very rarely. What is about second tumor, that is meningioma, we usually continue to treat.
Okay.
Also based on recent guidelines. Thank you.
So yesterday you were not here, we were preparing with the SP, so would like to give you this small gift and thank you for your contribution.